I'm going to talk about treatments and side effects, and then I'll hand it over to Dr. Kim, who will complete the discussion. Just some acknowledgments that I borrowed some slides from friends and wanted to thank them for that. Neither Dr. Kim nor I have conflicts of interest. So the goal for tonight is to discuss the current and future treatment strategies of treatment for juvenile myositis. I guess we're not going to focus much on future. We'll probably talk about that for the next webinar. I'm going to give you information about the immune system because it's something you need to understand before you can really understand the treatments. And then Dr. Kim is going to talk about other medications that we use for initial treatment. And we're focusing on how the medicines work and what the side effects are. So to understand what we use to treat dermatomyositis, you need to understand where the name comes from. So dermato means skin, myo means muscle, and itis means inflammation. So we'll start out by thinking about the immune system by thinking about blood, not meaning to gross anyone out, but as you can see, can you guys see my pointer? Yeah? Okay.
Yes.
Perfect. Yeah. So here we have a diagram of a blood vessel, and inside blood vessels runs our blood. So blood has a liquid component, which is called plasma, and cellular components, which are red blood cells that carry oxygen, platelets that help your blood to clot, and white blood cells, which are the major component of the immune system. So we can divide white blood cells out into many different types. And if you are used to seeing your child's blood cell count results, perhaps on like your MyChart, or discussing the results with your physician, you might recognize some of these names of various types of white blood cells. The ones that are most important for fighting infection are called lymphocytes. And there are different types of lymphocytes, which you don't need to know, but some of these terms you might have seen before, like B cells and T cells. And there is a certain type of cell called plasma cells that make antibodies. There are other cells called T cells that make cytokines, which are inflammatory chemicals. And all of these cells and chemicals and antibodies are targets for our drug treatments that we're using for juvenile myositis. The other thing that you need to think about when we're thinking about myositis is, what are the targets of this inflammation? Where do these white blood cells and chemicals and antibodies go when they're making inflammation? So dermatomyositis is a type of condition called vasculopathy, meaning that the immune system is attacking the inner lining of blood vessels. So here we have some diagrams of blood vessels. We've got arteries that take oxygenated blood from our heart to all the cells in our body. And then we have veins that return the blood to our heart after the oxygen has been depleted. And in between arteries and veins are capillaries, which are the tiniest little blood vessels. And capillaries only have two small layers. They have these endothelial cells and then a basement membrane. And the endothelium, the endothelial cells, are what we think is a major target of inflammation in dermatomyositis or polymyositis, any type of myositis, the very inner layer of blood cells. Thinking about the skin, so the blood supply to the skin comes from kind of deep under the skin, and the little teeniest, tiniest capillaries come up right to the edge of the skin in these little things called dermal papillae. And these are the little capillaries where the immune system is targeting inflammation. So white blood cells come into these capillaries, they attack the walls of these vessels, and then the vessels become leaky, and white blood cells move out into the skin tissue, and that's why you get rashes. So those are the little papillae right there. Something really cool is that we can actually see those tiniest little vessels in the dermal papillae in one place in our body, which is right up at the cuticle of the fingernails. Right before the skin hits the cuticle, we have really thin skin right here, and those little capillaries, instead of pointing straight upwards, perpendicular to the surface of the skin. They run parallel to the edge of the skin. And what we can do is we can look with some magnification right in this area, and you can actually see little blood vessels. And in many patients with dermatomyositis, but not polymyositis, we see abnormalities of these little tiny vessels. So they should look like nice, beautiful little hairpins. And here we see thickening. And then here we can see that the cells, that the capillaries get dilated, and sometimes they make hemorrhages, and sometimes the vessels just drop away, or they'll get really bushy. And these are changes that we see in dermatomyositis, and it's basically telling us that those little capillaries, the endothelium, is being inflamed and irritated by the immune system. And then the last piece of anatomy to think about is the muscle. So our muscles are made out of many, many little tiny cells. So this is a picture of muscle coming out from the biceps, and there's different sections within the muscle called fascicles, and blood vessels run along the fibers in the muscle. And again, this is a place where we have inflammation. So inflammation is attacking those blood vessels in the muscle, and the white blood cells are leaking out of the vessels, and they're attacking in the fibers themselves. And here's a picture under a microscope. So this would have been from a muscle biopsy. And under the microscope, you can see the tiny little fibers in the muscle. So this is a healthy muscle right here. So these are the little muscle fascicles, and then even deeper magnification, those are the tiny little muscle fibers there. The nucleus of the cells is along the edges, and then the blood vessel supply is in between in these areas that separate the muscle fascicles. And this is a piece of diseased muscle. This is a patient with dermatomyositis. So what we're seeing is a lot of these kind of dark blue little teeny tiny dots. Those are actually white blood cells that are within, infiltrating or invading the muscle itself. And if you look closer, here's a little blood vessel that's in that separation between the muscle fibers, and you can see that the white blood cells are leaking out of the walls of the vessel, and it's starting to attack in the muscle itself. So that's what's going on in patients with dermatomyositis. Those immune system cells are attacking in the walls of the blood vessels, they're attacking in the skin and in the muscle. So what we do to treat an overactive immune system is that we target those white blood cells. So we are targeting the overactive white blood cells, antibodies that are attacking, and immune system chemicals, which we call cytokines. There are two ways to treat an inappropriately overactive immune system. So one is using medicines to suppress the immune system called immunosuppression. And another way is to change the activity of the immune system, but not really suppress the immune system, and we call that immunomodulation. So what we decide first is how sick the patient is, how weak the patient is, how bad the rashes are. And depending on how severe the patient is affected, that helps us decide how aggressively to treat. So we have two steps in treatment. The first step is called induction, or our initial treatment. And our second step is called maintenance, and those are medicines that we use over time. And we'll talk a little bit about maintenance medications today, but I'm going to focus mostly on steroid medications, which are part of induction. So medicines that actually suppress the immune system are steroids. Steroids work quickly, they work well, and we'll talk a lot about them in a few minutes here. And then Dr. Kim is going to talk about Methotrexate, which is a medicine that we use at the beginning, but we continue this medicine through, and so we call it maintenance treatment. For immunomodulatory medications, Dr. Kim is going to talk about IVIG, and you might be familiar with another medication called hydroxychloroquine or Plaquenil. So before we get started on steroids, I wanted to introduce you to something called consensus treatment plans. So consensus treatment plans for treating, options for treating patients with dermatomyositis were developed in 2010 by an organization called CARRA, the Childhood Arthritis and Rheumatology Research Alliance. And this was an attempt for pediatric rheumatologists in North America to standardize our treatment approaches to patients with dermatomyositis, and we have consensus treatment plans for some of the other conditions we treat, such as lupus and juvenile arthritis. And the reason that we came up with these plans is because many rheumatologists treated these conditions very differently, and we decided that it would be a good idea to be able to compare various treatment styles. So we agreed upon 3 different pathways that physicians would feel comfortable using to treat kids with moderately severe dermatomyositis. And it's important to know that these are not formal treatment recommendations or treatment guidelines. These are basically pathways that people can choose, physicians and families can choose together regarding how to treat a patient with myositis, but it's not necessarily the absolute right way to treat. So we have 3 different pathways in the consensus treatment protocols. All 3 pathways utilize steroid medications, which we're going to talk about in detail. I've put some abbreviations in here just because the slide is busy, but IV means intravenous or through the vein. Methylprednisolone is a type of steroid. For pathway A, we can use the steroids for 3 days in a row with an option to continue weekly IV steroids. Pathway B contains steroids as well, IV, and pathway C does not include IV steroids. The other steroid drug that is used in all 3 pathways is called prednisone, which is an oral steroid. When it's a liquid, it's called prednisolone. And we decided for the treatment pathways that we would use 2 milligrams for every kilogram that a child weighs every single day, with a maximum of 60 milligrams every day, and then weaning or reducing the dose. And that steroid plan for the oral steroids is the same through the 3 treatment pathways. The other medication that's used in all 3 treatment pathways is Methotrexate, which Dr. Kim is going to discuss. And then the last treatment that is used only in pathway B is intravenous Immunoglobulin, which Dr. Kim is going to discuss. So your child might be treated using one of these pathways, or the physician treating your child might be making some modifications to these different pathways. But this is what we're talking about when we're talking about the CTPs, or consensus treatment protocols. Just so you're aware, we have a tapering plan for how to reduce the dose of oral steroids for patients who are on the treatment plans. And depending on how much the child weighs, we reduce the dose at a specific time frame. And the plan for all of the treatment protocols is that patients would be off oral steroids in 50 weeks or about a year. So let's go into detail about steroids. There are a lot of different words that essentially all mean the same thing for steroids. So you might hear glucocorticoids or corticosteroids. There are different types. So there's prednisone, which are tablets, methylprednisolone, which is an oral liquid called Orapred, and prednisolone, which is reverse it. So methylprednisolone is the IV form that we also call Solumedrol, and prednisolone is the oral form in a liquid called Orapred. And there's some other types of steroid as well that we're not going to be talking about, but suffice it to say, if you see any of these terms, it's essentially the same thing. They're all talking about steroids. So steroids are hormones that are made naturally by our adrenal glands. So our adrenal glands are part of the endocrine system, and they live right here above the kidneys. And the function of adrenal glands is to make steroid hormones, and steroids, cortisol being one of them, have a lot of different effects on the body. And that's the reason why steroid medications have so many side effects. So one of the important things about steroids is that they are anti-inflammatory. And steroids have a lot of other effects on the musculoskeletal system, on your metabolism, so body fat distribution, weight gain. They have effects on the brain. They have effects on how cells use energy. So just lots and lots of effects in the body. The reason that we use steroids for treating inflammatory conditions is that they are very immunosuppressive. And it's important to know that steroids are very strong. They're like the Incredible Hulk. They hit you hard and they hit you fast, and they're really, really strong. So a little bit about the history of using steroids for juvenile myositis. Before synthetic steroids were made in the 1960s, a third of patients with juvenile myositis died. A third had bad complications of the disease, and about a third recovered. Prednisone, which is this steroid molecule here, was synthesized in a laboratory in the 50s and started being used by mouth in the 1960s. And in the 1970s, it was started to be used to treat juvenile myositis. And once steroids began being used for myositis and other conditions like lupus and juvenile arthritis, we had a huge reduction in the numbers of patients who died from the disease and the numbers of patients who had complications from the disease. It wasn't until the late 90s that we started using steroids IV to treat juvenile myositis. And when we give the steroid medications by IV, it enters the center of the cells and really shuts down inflammatory pathways in a different way. So we'll talk a little bit more about the IV steroid history. There was a study in 1998 where they looked at side effects of kids who received IV steroids for various rheumatic diseases. And about 22% of the kids reported, and their parents reported, side effects like altered mood, headaches, stomach aches, high blood pressure. We're going to talk about all of that in more detail. In 2000, there was a study done looking at juvenile dermatomyositis patients who received steroids by IV, not just oral steroids. And it showed that those patients responded about 2 years earlier than those treated with oral steroids alone. And response can mean a lot of different things, but essentially it meant that these patients got better faster, but it did cost a lot more to treat them, $13,000 more. But if you think about it in the way of disease being avoided or patients getting better faster, it was cost about $7,000 a year. And in 2008, another study was done looking at the differences in absorption, the way that the body receives the steroids, and how effective the IV methylprednisolone or the IV steroids were versus oral prednisone. And then again in 2010, the CARRA protocols included IV steroids. And the reason that we're going to talk a little bit about IV steroids is that they may be important for treating this disease in order to get better absorption, especially in patients who have a lot of damage to their blood vessels or vasculopathy. So what happens is when we take medications by mouth, they go through our mouth into our stomach, and then the lining of the stomach is where the steroids get, or any medication gets absorbed into the bloodstream. So the medications have to go from the lining of the stomach into the little blood vessels, and then they get absorbed into the bloodstream. And when you remember those Nailfold capillary changes, if kids have abnormal capillaries, that probably indicates that the little blood vessels in their stomach are also abnormal, and that it might be harder for medications to go through the stomach lining into those little blood vessels. When you give steroids by IV, they actually go straight from the skin directly into the blood vessels, so you bypass that absorption that has to happen from the stomach. So we'll talk now in detail about steroid side effects, and this is just a summary slide that talks about all of the different side effects of steroids. And I know that this has to look very scary because steroids have a lot of side effects, and it's always important to know that we are always thinking about risk versus benefit. And even though steroids have a lot of side effects, they're really important because they work fast and they work strongly in the beginning. So the benefit of steroids actually outweighs risks, at least in the beginning when we're trying to get the disease under control. So you can see the little abbreviations on the side here just to help you know what side effects of steroids are permanent versus reversible and how likely they are to potentially happen, definite, possible, or rare, and then dangerous with the little red flag. And we'll go into all these in detail now. So the most important effect of steroids is that they suppress the immune system. So remember that they reduce the immune system's ability to fight infections, and that can be dangerous if there are severe infections that happen. In all of the slides upcoming, I'm going to talk about mitigation, or the way that we make steroid side effects better, and those are always going to be in italics. So what we can do to screen patients for possible infections is we can check them for tuberculosis before we start steroids. And we can evaluate for any other infections that might be happening. We can also prevent infection by giving immunizations. And Dr. Kim is going to talk about IVIG, which actually helps to prevent infections. And it's also important for patients to get checked for infections if they have a fever while they're on steroids, and take antibiotics if they're prescribed. Other immune system effects from steroids is that they can change your white blood cell counts. So initially white blood cell counts go up when we start steroids, and then they usually go back to normal. It's rare for steroids to cause a low white blood cell count. There are also a lot of effects of steroids on the endocrine system. So most people who have started steroids know that they make you gain weight, and they make you gain weight for 3 reasons. One is that your metabolism slows down. It changes the way that your body takes on fat. Steroids also make you really hungry, and the third reason that you gain weight is because they make you retain salt and fluids. It's essentially definite that a patient is going to gain weight from steroids. I've had a few young patients who haven't gained much weight, but when a patient doesn't gain weight on steroids, then we wonder if they're actually taking their medication. So this is why we get patients get Cushingoid features, is that they gain weight in their cheeks, belly, and the back of the neck. And that's due to the way that steroids make you distribute fat across your body. So things that we can do to help with weight gain is to make sure that our patients are eating a healthy diet that's low in fat and sugar and salt. Also, exercise is really important, and it's important for families to keep healthy snacks available because the kids are starving. They're hungry all the time. Salt retention is another endocrine effect, which can make your skin get puffy and can raise your blood pressure. It's quite rare for patients to actually develop diabetes when they're on steroids, but it is something that can happen. And you would see that a patient would be getting thirsty very frequently, urinating a lot more. And we do screening when we get blood tests to look at blood sugar levels. And if there is an abnormality in the blood sugar and we're concerned about steroid side effects causing diabetes, we would make a referral to endocrine doctors. Another super important side effect of steroids is something called adrenal suppression. So basically our adrenal glands that make natural steroids go to sleep. And these natural steroids are really important for supporting critical body functions. So in times of stress, such as fever, infections, surgeries, or serious injury, our body's adrenal glands are not going to be able to produce enough steroids to help with a stress response. And so that can be dangerous or life-threatening. Symptoms of that would be developing fever, abdominal pains, headaches, vomiting, sleepiness, low blood sugar, and then as time goes on, blood pressure can drop, which can be very severe. So the way that we prevent adrenal suppression is that we make sure that our patients take steroids every day and never stop them abruptly, no matter how much they hate the side effects. It's important to make sure you always have plenty of steroids at home, and maybe even keep extra doses around, so if steroids are forgotten, they can be taken quickly. When a patient does have high levels of stress, like bad infections, if they're admitted to the hospital, then we use something called stress dose steroids using a different formulation called hydrocortisone. And someone asked a question about this. We give stress steroids mainly when patients are sick in the emergency department or the hospital, not necessarily when they're having fevers at home. Some rheumatologists will send their patients to an endocrine doctor who might say that you should use stress dose steroids for any type of fever. There are a lot of kind of different pieces of advice that people can get, but certainly stress dose steroids should be given in times of severe stress. It's really important to know that the adrenal glands, when you are taking steroids, they fall asleep and they take a long time to wake up. So it's really hard for them to make a burst of steroids quickly. This is why we reduce steroids very slowly and we taper the dose. And when steroids are tapered, we generally go down by 10 to 20%. So that means as the steroid dose goes lower, then you decrease by smaller numbers. And some doctors will actually wean steroids to every other day. Some other important side effects of steroids have to do with the gastrointestinal tract, so you can get gastritis or irritation of the stomach. It's important to take steroids with food every time they're taken to make sure that the stomach lining doesn't get irritated. And most rheumatologists will prescribe an antacid medication like ranitidine or omeprazole. There's various ones. Someone asked online if you have to take acid suppression medication or if you should just wait to see if patients have side effects from stomach irritation. I think most rheumatologists would agree that it's really important to go ahead and take acid suppression, because if you don't, the effects are going to build up over time and cause more problems. But not every rheumatologist feels the same way. A very rare side effect of steroids on the GI tract is getting air in the walls of the intestines. That can be very dangerous, but it's something that is exceedingly rare. And it's actually controversial whether the steroids cause this or whether the disease of myositis itself causes it. And we think that patients might be at more risk if they have skin ulcerations, because they can get similar ulcerations on the inside of their intestines. So that's getting to skin. The side effects of steroids on the skin are quite a few. Patients can develop stretch marks. I see it less in children who are younger, more in kids who are older, and more in patients who gain a lot of weight. Important to keep the skin well moisturized to help the skin stretch. We think that scar treatment creams are generally not helpful. Steroid-induced stretch marks are permanent. Many years after steroid stretch marks are made, some dermatologists say that you can reduce their appearance with a laser treatment. Steroids will also cause acne, and so there are various types of medications, treatments on the skin that can help to reduce acne. Steroids can make patients a little more hairy, but that'll fall out. And then that swelling of the skin that I talked about. Another effect of steroids is on growth. And we know that patients who take steroids, it can slow their growth down, their linear growth or their height, but they almost always catch back up. So this is a picture of a growth chart of a patient with lupus who was on steroids for 3 or 4 years, longer than most kids are for dermatomyositis. And this patient was probably following a curve of her growth, and then she slowed down, and then as she went off steroids, she went back up to the same line she was at before. And it's also important to note that her weight, which was probably increasing normally, went up high when she started steroids. So in a patient with dermatomyositis who might take steroids for a shorter period of time, they would probably grow more quickly. Another thing that we commonly see in patients who are taking steroids is that their weight can go up and will, as time goes on and their steroid dose goes down, they will lose weight and go back to where they were before. But that's only in patients who work hard in their diet and exercise. It's unusual for patients to have delayed puberty. Psychiatric and mental health effects also happen. Steroids can reduce the ability to fall asleep and stay asleep, so there's sleep disturbance. Steroids can also cause mood disturbances. That's important to know that kids can get irritable from steroids and not to blame them. And this is a good reason to think about doing counseling or talk therapy to help with some of these mood disturbances from steroids. It's exceedingly rare for patients actually to have psychosis from steroids, When this happens, we rapidly reduce steroids as safely as we can, and we can use medicines to help it. And these are all reversible side effects. There are some rare side effects on the nervous system from steroids. Something I've never seen before would be nerve pain. Another rare effect would be increase in the fluid around the brain, the spinal fluid, and increase in the pressure. And that would be seen in patients who have that. They might get severe headaches, especially in the morning. This is a reason that it's important to go get eye exams, the eye doctor, because they can see some changes in the eyes. Finally, we'll talk about cardiovascular effects of steroids. So steroids can increase blood pressure, and here are some symptoms that can happen. When this happens, we reduce the doses of steroids and we make sure that the patient is reducing salt in the diet. It's unusual to need medicines to reduce blood pressure, but they can be very helpful. Another thing that steroids can do is cause cholesterol or fats or lipids, all kind of the same thing in the blood, to increase. There's a higher risk if there's a family history. So many physicians will check blood tests every year to look for elevations in cholesterol. It's unusual to need medicines to reduce this, but these can cause long-term side effects, such as hardening of the arteries or blood vessels getting clogged with cholesterol that can be irreversible. So it's important to control lipids, but it's also important to know that because blood vessel damage in dermatomyositis can put patient at risk for cardiovascular disease too. So sometimes it's hard to know if cardiovascular disease came from the disease itself or the medication. Just a few more slides here. So effects of steroids on the eyes. Steroids can increase pressure inside the eyes, which is something called glaucoma. It's rare for that to happen right away. We like patients to go to the eye doctor within a couple months of starting steroids, and then every 6 months to check the pressure in the eyes, and to also look for cataracts, which are clouding of the lens inside the eye. That's a later effect of steroids, and they can be permanent, although I have seen some kids with cataracts improve. So my last couple slides are just some checklists that you can review to help you, things that help treatment side effects. Taking calcium and vitamin D to protect bones. Steroids can take calcium out of the bones. Also taking acid protection medications, and then thinking about referral to an endocrine doctor if there are endocrine concerns, and definitely referral for counseling. Someone asked online if stress can affect the way that the disease affects the body. And it's a complicated answer, but we do know that stress can affect the immune system, and we know that some patients who have dermatomyositis and are under a lot of stress can cause their disease to flare. So it's an important reason to reduce stress in patients who have dermatomyositis. Because we've talked a little bit about IV steroids, there are things that you can do to make IV placement easier. There's something you can buy on the internet called the Buzzy, which is a device that helps to reduce pain from needle sticks. And here are some other things that can be done to help patients who have stress with their IV sites. We generally don't recommend using more permanent IV access like a PICC line or a port because of the risk of infection. So in the end, we talked a lot about steroid side effects. The way that we can avoid side effects is to avoid steroids, and that means we use steroid-sparing medications like Dr. Kim is going to talk about here. We also think that treating our disease aggressively more in the beginning might help us to avoid the need to use steroids later. And there is a new steroid formulation that's coming down the pipeline called vamorolone that works in a different way. It doesn't get into the nucleus of the cell to cause a lot of the side effects that steroids cause. So this is something that's very exciting that it's undergoing clinical trials. So in conclusion, steroids work, but they are very difficult medications because of the side effects. And I call them to my patients, I say that steroids are your frenemy, because in the beginning, they're your friend because they help get you better. But as the side effects accumulate over time, they become more of your enemy. And as physicians, we want to use less steroids, And we need to find other steroid-sparing medications that work fast and work well. So I'm going to turn it over now to Dr. Kim, who's going to talk about other medications.
Thank you, Dr. Curran. And as we transition to Dr. Kim's slides, I know that we had slated this webinar to end at 8:45, but we want to make sure that we get you all of the information, including sun protection and physical therapy. So we're probably going to run a little bit long, maybe closer to 9 o'clock. So hope you guys are okay with that. We just want to make sure everybody gets access to the information. So thank you, Dr. Kim, and she will start her presentation.
Hi, thank you for the opportunity to go over this with everyone, and thanks to everyone who's joining the WebEx or this web presentation and for your questions as well. So like Dr. Curran mentioned, I'm going to be going over some of the other medications, Methotrexate as a first-line agent, Hydroxychloroquine as an adjunct medication, and intravenous immunoglobulin, which is also commonly referred to as IVIG. And both methotrexate and IVIG are also referred to as steroid-sparing agents. And other adjuncts that I'm going to mention at the end are sun protection and physical therapy. So first, methotrexate, which is sometimes abbreviated as MTX, can be taken either as an oral medication or as a pill, as shown over here. Sorry, I'll use this. Or as an injection, shown over here. And its mechanism of action is pretty complex, but in a general sense, it's thought to work on the building blocks of cell proliferation or cells that divide. And because in juvenile myositis, we know that the immune system is very activated, we think that it works by helping address the cell proliferation in the immune system. Of note, it also works in a pathway that involves folate or folic acid, which is related to why often folic acid is taken with methotrexate. I show this calendar here because it's been shown in studies that the side effects are minimized by taking methotrexate once a week, either when it's taken by mouth or by injection. And it's usually taken towards the end of the week because most of the side effects happen the day or two afterwards to minimize the side effects affecting school. So some of the most common side effects are abdominal discomfort, loss of appetite, nausea, and intolerance. At least part of the reasoning we think behind some of these side effects is we know that the cells that line the stomach are some of the cells that are also rapidly turning over. Oral ulcers can happen, and we know that mucosa is also a rapidly turning over cell. And this is just an example picture, not very appetizing. And slow hair loss has also been described as a side effect of methotrexate. And the way that we try and address these side effects is by adding folic acid or folate, usually at a dose of 1 milligram per day as a vitamin, which doesn't have any negative side effects of its own, to help address some of these side effects. And we haven't seen that by taking folic acid that it takes away from any of the efficacy or takes away from how well the methotrexate works in juvenile myositis. Other ways to help reduce these side effects are to reduce the dose of methotrexate, or if you started with the oral dosing of methotrexate, to switch over to the injection dose of methotrexate, because using the injection format can bypass some of the abdominal side effects. Also, I forgot to mention, but as Dr. Curran mentioned, because the vessels are one of the primary targets or involved locations in juvenile myositis, in general, we do try to start with the injection form of methotrexate if possible, because we know that it's better absorbed. But for different reasons, sometimes someone may start with the oral medication as well. And then there are some side effects that in the blood work. So one thing that can be seen is the elevation of liver enzymes, which is a blood test. And this happens without any symptoms that you can see or feel. And this graphic is just a picture of the liver organ. And another thing that can be seen in laboratory tests or blood work are changes in the blood counts. So you could have a lower white blood cell count, anemia, or changes in your platelet count, which are also things that are not really associated with anything you can see or feel. And the way we address this is by monitoring these things in the blood regularly. And this is typically done about every 1 to 2 months when you start methotrexate, and then every about 3 months once you're on an established dose. Another side effect that can be seen in general, as Dr. Kern kind of mentioned, with the medications that affect the immune system, because they're doing what we hope that they'll do to help fight the juvenile myositis symptoms by kind of turning down the immune system, it also decreases your immune system's ability to fight infections, so there's a potential increased risk of those. And while there are no standard guidelines for how to address this possible increased risk for infections, many pediatric rheumatologists may tell you to hold a dose of methotrexate while you're taking antibiotics for infection, or if there's any sort of infection where it is a more severe infection, and also before and after major surgery to help your body heal and tolerate the stresses of a surgery. And in general, there are different types of vaccines. Most of the vaccines are killed vaccines where they don't include any active things that could cause an infection. So most of the vaccines are killed vaccines, but live vaccines are usually very weakened forms of an infection that can be given, and a normal immune system would never be, would always be able to fight those off, and you would never get the infection from that. But when someone's immune system is suppressed or turned down a bit, there's a higher chance of actually developing the infection. So generally we recommend to hold live vaccines while getting a medication that suppresses the immune system. And some examples of live vaccines are varicella and the MMR vaccine, which is measles, mumps, and rubella. Those vaccines are usually given at 1 and 4 years of age. In general, good hand washing, like for anyone to try and avoid getting sick, is good practice, like around the time when you go to the bathroom and when you're in large groups and before eating as you normally would. And of course, trying to avoid direct contact with individuals that you know have an infection or are sick. And there are some things that are more strict contraindications, so that conditions in which we would not use methotrexate. One is pregnancy. So for females that are pregnant, it's contraindicated because it can be dangerous to the pregnancy. And because we know that the liver can cause an irritation to, methotrexate can cause an irritation to the liver with the elevation of liver enzymes, and sometimes can cause rarely worse side effects to the liver when someone is an alcoholic or has other known chronic liver disease. It's not recommended to use methotrexate. Or if someone already has very low blood cell counts before starting the medication, or a different type of underlying immunodeficiency, then methotrexate is not recommended. And there was an online question about chemotherapy type side effects of methotrexate. And this is a good question because methotrexate was initially used and studied as a chemotherapeutic agent, but the dose that we use in juvenile myositis is a much lower dose. I think they had asked specifically about like brain effects or nervous system effects, which are very well described when methotrexate is used at a chemotherapeutic dose, but those side effects are not side effects that we see in these lower doses that we use in juvenile myositis. In general, nonspecific symptoms like headache or fatigue can be described at this lower dose of methotrexate that we use, but we don't see the chemotherapy type of effects. So next medication I'm going to talk about is hydroxychloroquine. This is sometimes abbreviated as HCQ, and the brand name of it is Plaquenil. So this is an oral medication. It comes in a 200 milligram tablet, and this is dosed in a weight-based dose of 5 milligrams per kilogram, generally per day, and it can be either given once a day or divided into 2 doses a day. This was initially developed as an anti-malarial medication, and its exact mechanism of action or how it works in juvenile myositis is not really well established, but it is generally thought to decrease inflammation and immune cell function. It is considered an adjunct medication because it's, in general, not thought to have a very strong effect on the immune system, but because, like I'll mention in a few minutes, it doesn't have very strong side effects, it is sometimes thought to be a helpful adjunct. It has been shown in studies to help with like milder disease, and particularly with skin disease, and in some studies, at least as an adjunct, also to help with muscle disease. So as mentioned regarding the side effects of Plaquenil, it is generally considered to be safe, but there are some gastrointestinal side effects that have been described: gas, diarrhea, nausea, and vomiting. There have been skin changes that have been described, like darkening of areas or rash. In general, these side effects can be reversible with a dose reduction, and actually a lot of these side effects may go away on their own while continuing the medication at the same dose. Of note, it has been described also that some people may develop anemia when they're on Plaquenil, but this is generally only if that individual has another condition called G6PD deficiency, which you would usually know beforehand. Another side effect that is more of something that requires monitoring but not a major concern, and because it's not very common, is the eye toxicity. In very rare cases, usually at higher doses over longer periods of time than it's used in juvenile myositis, there can be a risk of vision loss. So it is recommended to have a detailed eye exam with an ophthalmologist that includes an assessment of the back of the eye or the retina and a check of color vision before starting. But this is only something that's seen after many years of taking this medication, and again, usually at higher doses, much higher than what we usually use in our patients, but it's something that if you are on this medication, your doctor will talk about with you. So the last medication I'll be talking about today is intravenous immunoglobulin, or IVIG. So as you can see in the name, this is a medication that has to be given via IV, so you have to have an IV placed, and it's given over many hours. The dose is usually by weight, so it's 1 to 2 grams per kilogram. And because it takes a long time, sometimes the dose is split into more than one day. And as Dr. Curran had shown in the consensus treatment plans, or CTPs, in general, it can be started at 1 dose given every 2 weeks for 3 doses, and then monthly. But there is some variation in this based on how someone responds to it and how severe their disease is. So what immunoglobulin is it's essentially antibodies. It's collected in bulk from healthy donors, and immunoglobulins are selected out, and then that solution is screened and sterilized for known infections, and then given in an infusion. And it's thought that this immunoglobulin or antibody IV bulk dose acts to calm down the immune system kind of globally. And because it's so many different antibodies, it's not specific to a certain infection or bacteria or virus. It can also help protect you from infections. So rather than suppressing the immune system, it helps protect you from infections and also helps calm down your immune system. And also there was a question online about this, about whether or not IVIG could help someone reach remission. And of course it's different for each individual, but it has been studied, particularly for people who have not had a good response to other medications before this. So refractory cases, which are more difficult cases, that by adding IVIG, they can have benefit in both their strength or their muscle disease and in their skin rash. And there has been some studies about it helping with calcinosis as well. So there are no guarantees that adding this will lead to remission, but it can in some patients. It's also unpredictable how long it can take to get benefit, but it has been shown to be helpful. So it may lead to remission for some people. So what are some of the side effects we can see with IVIG? One of the more common side effects that can be seen is headache, and another thing called aseptic meningitis. So the itis in meningitis means inflammation, and the meninges are the lining around the brain and the spinal cord, so there's an inflammation there. And then aseptic means that there's not a true infection there, it's just like an irritation inflammation. And this tends to happen more when there's a very high dose of IVIG that is used. And the doses that we tend to use in juvenile myositis are higher doses in general, and or if the infusion is given very rapidly, so a large dose is given over a shorter period of time. Nausea and vomiting is another more common side effect. And flu-like symptoms, including fevers and chills, diarrhea and achiness, and sometimes rash or itching are other side effects that can be seen. In general, these side effects can happen during the infusion and then in the 1 to 2 days after most commonly, and generally self-resolve after 5 to 7 days. And we try to address and minimize these symptoms by encouraging either like at home good oral hydration, like by drinking a lot of water in the 24 hours before receiving IVIG. For some individuals, they get just some IV fluids right before starting the IVIG to maintain better hydration, and also by slowing the rate of infusion. Generally, the doses we use in juvenile myositis take hours to give, at least so several hours over 1 day, and sometimes because of the large dose and also this risk for side effects, it can be split into 2 days. There are different formulations of IVIG, and using formats that have less glucose or sugar in them, so they're kind of less thick or have a lower osmolality, those tend to have less of these side effects. So sometimes, oftentimes your pediatric rheumatologist has already identified the types or brands of IVIG that have less of these side effects, but sometimes trying a different brand will work better for your child. And in general, even with the first dose of IVIG that's being given, pre-medications are used because some of these side effects are pretty common, such as acetaminophen or Tylenol, diphenhydramine, also known as Benadryl, or sometimes a small dose of steroids is given just as a pre-medication as well. Other side effects that can be seen with IVIG is anemia. And rarely, and so I've never heard about these side effects happening, and I think they're more described in adults, but I just mentioned them because they are described, are with IVIG, blood clots, there is a higher risk of blood clots and of kidney dysfunction. But the kidney dysfunction is particularly with like the more thick or formats of IVIG or those with higher sucrose or glucose levels. So to help address these, we monitor labs, including checking for anemia. We want to make sure someone's hydrated well to decrease the chance of the blood clots and kidney dysfunction, avoid those types of formulations that have higher sucrose or higher viscosity or thickness, and if possible, try to avoid take other things that may increase someone's chance of clots. And one thing could be estrogen-containing medications, like in birth control pills. Another rare side effect that can be seen with IVIG is a very severe type of allergic reaction called an anaphylactic reaction. This is particularly a higher risk if someone has a particular condition where they don't have an immunoglobulin called IgA. And the reason for this is because when they receive their IVIG, that might be the first time they get exposed to IgA, and then their body reacts to that as a severe allergic reaction. And it's associated with having a rapid fall in blood pressure. So to help avoid this, IgA is something that can be tested with a simple blood draw. So we can check for IgA before starting IVIG if possible. And regardless, every time someone gets IVIG, there are standard protocols for monitoring blood pressure during the infusion or while it's being given. And also commonly, because anaphylactic or allergic reactions with IVIG are kind of unpredictable, they may happen even if someone is not IgA deficient. they're still rare, but they're kind of unpredictable. So oftentimes emergency medicines are ordered to be available at the time of infusion, like epinephrine or any type of medications used for anaphylactic reactions. So they can be used very quickly if needed. So with vaccinations, the vaccine is some form of a bacteria or virus that the body gets exposed to, and it's used to teach the body how to fight that infection without having to go through the infection itself. But when you're getting the antibodies or this immunoglobulin kind of in this bulk dosing, the body may not have the chance to learn that response because it's getting all of this antibody from the outside. So it can affect how well your body learns that vaccination response. That is not dangerous for you because you're still getting protected from that infection from the bulk antibody. But it's just something to consider. So if possible, it's good if you can try and complete as many vaccines as you can before starting IVIG, but often that's not possible. So it's just something to keep in mind. You can always check how your body has developed its response to the vaccines after completing IVIG course and get additional doses of vaccines if needed afterwards. So finally, some other adjunct therapies that we wanted to talk about are, one is sun protection. So we know that the rashes in juvenile dermatomyositis are generally thought to be photosensitive or sensitive to UV or the sun exposure. So, and there's some variation from person to person and how much someone feels like that their disease is correlated to their sun exposure. But in general, because it has been shown in some studies, and it can certainly be for many people with juvenile myositis, we do recommend sun protection for everyone pretty aggressively. So that would mean like maybe SPF 30, application to all sun exposed areas with any significant sun exposure, and reapplication multiple times a day because the sunblock that you use won't last all day. It usually only lasts for like 90 minutes or a couple of hours at most. So this can mean sunblock application before going to school, before going outside to recess or to lunch, and also probably before going back home from school if possible, because you can still get some exposure through windows and even with limited outdoor exposure. And then other things that are recommended are trying to use long sleeves and long pants when possible, hats that have wide brims that cover all the way around, and discussing with the school these things is something that your doctor can help you with so that you can have extra time to apply the sunscreen and limit sun exposure when possible. Oh, and there was a question about a particular type of possible sun protection in an oral pill with like a fern blocker called Heliocare. So this is not something that I personally have experience with, but I did ask some of the dermatologists that I work with about this. So there have been some studies in small groups of adults that have looked into this oral. It's considered like an herbal possible sun protectant and antioxidant. And there are some promising studies, but it hasn't really been studied long term and not studied at all in children that I could find or that they could find. And even in general, I don't think anyone would say that this oral herbal pill could replace the other sun protection measures that I mentioned, but it's certainly something that could be promising as an adjunct sun protective measure in the future, and something that can consider or continue to consider discussing with your doctor or dermatologist. And finally, the last thing I was going to talk about was physical therapy and physical exercise. So we know that juvenile myositis is something that can affect the muscles, sometimes quite severely, such that your function is very affected. But even when someone is having very severe disease, there's always some measure of activity that you want to try and maintain for your own health and quality of life. And there are different levels of activity that can be maintained in discussion and under supervision of a physical therapist, ideally someone who's familiar with juvenile myositis. But even when someone is very affected and perhaps not even able to walk and do all your typical activities of daily living, maintaining range of motion is important. So that means like learning exercises from a physical therapist that you can continue doing on your own to go from fully bent or flexed in all your major joints to fully extended or stretched out, like in your knees and in your hips and your shoulders and your elbows. And the reason for this is even if you're not strong enough to do that on your own, maintaining that range of motion helps you keep that range of motion longer term. Because if you don't keep moving them, you can lose some of that range of motion over time. And additionally, even though someone has muscle activity, there is some aerobic exercise and muscle strengthening that can be a benefit. And there have been studies to show that even in juvenile myositis, where we know the muscle is affected with inflammation, some levels of muscle strengthening and exercise are beneficial because they'll help you get back to where you were before disease and your quality of life can improve. And there isn't any evidence that this exercise or strengthening is bad for your disease, because there has been concern in the past about this causing flare. But we found that actually it probably is good for you and your quality of life and for your disease course overall to, in a structured way with a physical therapist, build a program including aerobic exercise and strengthening when you're able to help you get back to where you were. So those are what I was going to cover today. Thanks for your attention.